Hey everyone, Dr. Matt Geller here. I'm here with Dr. Dan Epshtein, one of my good friends. We're talking diabetes today. How big of an issue is diabetes? Let's hear some of the numbers.
Well, thanks for having me. So, according to the CDC, we have about 30 million people with diabetes in the U.S. and about 84 million with pre-diabetes.
Okay.
So, if we're talking about something like 330 million in the U.S., that's about a third of people in the U.S. that are at risk for developing diabetes-related complications. So, in my practice, I work in a hospital in New York City. So I have a bunch of patients with diabetic. There's a lot of what I do. Maybe 50% of my patients are diabetics.
Yep.
Just last week I had a patient, 23 A1C. He's only 27 years old.
Wow. What's your kind of algorithm? What's your workflow? How are you thinking about each patient? Give me the kind of the lowdown of your workup.
So the first thing I always do is ask how long have you been diabetic. You want to know if they're type 1 or type 2 diabetics, and then of course their A1C. If the patient knows that, that's already a great help for me, but fortunately a lot of patients don't. But going forward, of course, you want to do a full dilated exam. You want to ask the patient, are they having any problems? Like you have a patient with 23 A1C, had a lot of visual fluctuations, which makes sense. Sugar was through the roof. But as that stabilizes, patient's vision will change, even if they don't have any retinopathy.
What are you seeing manifest, right? What's the top 5 kind of conditions in order, roughly, of where you're seeing manifestations from poorly controlled blood sugar?
So of course, we have retinopathy, we have earlier cataracts. Dry eye is a big one that I see. A lot of my diabetic patients have dry eye also. And then of course you have patients with vasculopathies, like, you get BRVOs, BRAOs, things like that as well.
What are your favorite diagnostic tools that you're using to spot these things?
So OCT, that's the workhorse in my practice. I'm a big OCT fan. And it's not good just for figuring out, does someone have diabetic retinopathy, diabetic macular edema, but also following these patients. So I think a lot of the new research coming out, and maybe some of these patients that we were injecting or doing laser on, that we don't need to do it as early on as we thought, that you can monitor them. So that keeps the patient in our chair as long as you have the proper tools to manage and follow these patients.
And being in a hospital is kind of unique, right? Because you're working alongside so many other clinicians. What's the co-management and other relationship with other physicians like?
So it's great for me because I get to see everyone's charts, and I see the endocrinologist is concerned about this, the podiatrist is concerned about a diabetic ulcer, different things like that. It gives me a look into the patient's physiology at that point, because we know that if a patient has kidney disease, they're more likely to have diabetic retinopathy and vice versa as well.
Do you have any theories or kind of Dan-isms that are unique to this topic, or that you feel are underlying processes or things that people aren't looking at, they're missing, just any special sauce to it?
Well, I think OCTs have become more important. So nowadays we look at patients just fundoscopically and we say, I'll see you back in a year, I'll see you back in 6 months. Of course, we correlate that to their A1C, if it's trending up, if it's trending down. But I think going forward, looking at OCTA findings and seeing how effective is the foveovascular zone, how much non-perfusion, capillary dropout there is, that will help us figure out, okay, this patient has a higher risk for worsening diabetic retinopathy or worsening disease, and we'll maybe see those patients back a little bit earlier. So it won't be just what we're looking at, it's really what we can see with our imaging devices more so.
How are you educating and helping outcomes just through your words?
So in my exam room, I have a regular computer like everyone does, and I save a fundus photo that's normal and an OCT photo that's normal. This way I can show patients, this is how it's supposed to look like, and this is you with all the hemorrhages. I think when patients see, that's my eye, it's a different story. Us saying, this can lead to irreversible blindness. Because a lot of patients think, it's like a cataract surgery, 10 minutes and you're out, then you see great. But a lot of these conditions, you're not getting much vision back. And I think also once you start referring them for tertiary care, that's when they realize, okay, now I gotta really do something about it.
Yeah. So last question, where does optometry fit within diabetic eye care as a whole?
So I think that's gonna be our bread and butter going forward, because what's gonna end up happening is those patients who don't need intervention other than being told, control your sugar better, and we're gonna monitor you carefully, we could keep them in the office, because our retinal specialists, our general ophthalmologists, they're getting very busy with surgical cases and tertiary care. And a lot of times they don't want to see the patients with a mild NPDR. And those patients have other issues too. So even though they're brought in for this diabetic care, we're taking care of their glaucoma, we're taking care of their dry eye, taking their glasses. So these patients, they're sort of made for us with these chronic diseases.
I think diabetes education is just so critical, and it's certainly a place we fit in, because your work on the topic's excellent, and I love that you're pushing us forward in that regard. So yeah, thanks for that.
Well, thank you.
Yep.
We keep trying to push forward.
Yeah, looking forward to more from you on the topic. Thanks for coming on. Appreciate
Thanks
it.
for having me.